I'm Dr. Kaladhar from Yashoda Hospitals, Malakpet. So welcome to Tuesday Masterclass webinar from Yashoda Hospitals Critical Care Medicine Department in association with Hyderabad IDCCM chapter. We bring forth the regular topics for exam point of view for DrNB students, IDCCM students. It's widely useful. They watch these videos live and even after recorded versions before exams. Most of the people that given feedback that they're very much useful for their exams. So today we have two senior seasoned clinicians and examiners. One is Dr. Narendra Rungta sir. He is a past ISCCM president, well known. He is basically founder, chairman, and managing trustee of Critical Care Foundation in Rajasthan. So sir is very well known and renowned critical care physician. And we have Dr. Sai Satish with us, senior consultant neurologist from Yashoda Hospitals, Secunderabad. Today, topic for discussion is snakebite envenomation, which is a very common thing across India. Most of the people, especially in the critical care colleagues, they come across this problem, how to manage and all. So to bring forth this topic, we have a good, nice case to present that Dr. Keerthana and Dr. Chandana are with us. Both are second year DrNB CCM critical care medicine students from Apollo Hospital, Jubilee, Hyderabad. So I welcome you both on board. Keerthana and Chandana, you can proceed with your presentation. Another thing is basically Dr. Narendra Rungta sir and Dr. Sai Satish are a bit engaged. Probably they will be joining in between. So meanwhile, we will start the presentation. We'll go slowly and probably once they join, we'll take over.
Yes, sir. Okay.
Please start. I think I have to share the screen. So starting the slides. Are you able to see?
Yes, sir.
Yeah.
Can we start, sir?
Yeah, you can start.
Okay, sir. Good evening, everyone. So this is a 36-year-old female patient, a homemaker, hailing from Ongole. So she had an alleged history of snakebite over the right foot on 17th of November at 6:30 p.m. She was initially taken to a government hospital where she had received 15 vials of ASV. At that time, her whole blood clotting time was more than 30 minutes. On 18th, she again went to another hospital with complaints of multiple episodes of vomiting and decreased urine output, where she received 10 vials of ASV. Next slide, sir. So these were the trend of the investigations that was done at her outside hospital admission, sir, from 18th to 23rd. So what we observed here was there was a progressive decline in the hemoglobin from around 10.9 initially to 5.1, and there was a drop in the platelet count too, from 42,000 dropped to 16, then 22, 46, and so on. And she also had
Hello, Dr. Keerthana. I think there is some disconnection problem.
Yes, sir. From there, and I think they got disconnected. 1 minute.
Call up to them.
hello.
Yes, ma'am. Please continue.
Yeah, so the ultrasound abdomen showed hepatomegaly, GB wall edema, mild ascites, bilateral pleural effusions, and her peripheral smear showed dimorphic anemia, neutrophilic leukocytosis, and thrombocytopenia. Next slide, sir.
Keerthana, 1 minute. Sarah joined. Just I will make him to join here and then we'll proceed with the presentation. Is it okay? Yeah.
Yes, sir.
Good evening, sir.
Good evening. Sai, good evening. Kaladhar.
Narendra sir is joining, sir. 2 minutes.
Yeah, yeah. Good. So for the interest of the both examiners, can you both go to the first slide also?
Yes, sir.
First slide, please.
1 minute, sir.
Sai Satish, are you there, sir? Good evening.
Good evening, everybody. Good evening, Venkat,
Good
Dr. Kaladhar.
To just emphasize that this program, which we actually were bringing for the last 3 years, Dr. Rungta sir was one of the inspiration for this. And for toxicology, he has been a pioneer in bringing textbook of toxicology and doing a lot of work, including the spectrum of different toxicology audit or a data collection, which is happening at the front end of both the IDCCM and Rungta sir. Sir, we welcome you on board, and it is our honor to have you on board, sir.
Thank you. And Keerthana and Chandana, please go on.
Good evening, sir.
Sai Satish is there?
Sir, he is with the patient. He'll be there in another 10 minutes.
Yeah, no issues. Please, please carry on.
Yeah.
Okay, sir. So here we had a 36-year-old female patient, a homemaker, hailing from Ongole. She had a alleged history of snakebite over the right foot on 17th of November at 6:30 p.m. She was initially taken to a government hospital where she had received 15 vials of ASV. Her whole blood clotting time was more than 30 minutes. And on 18th of November, she went to another hospital with complaints of multiple episodes of vomiting, decreased urine output, and she had received 10 vials of ASV. Next slide, sir. So this was the trend of her labs during the outside hospital admission, sir. There was progressive decline in the hemoglobin, thrombocytopenia, AKI, sir, creatinine was elevated, and unconjugated hyperbilirubinemia, sir. From started off with 5.09 and ranged up, increased up to 7.2. And her 2D echo screening was normal. Her USG abdomen suggested hepatomegaly, gallbladder wall edema, mild ascites, and bilateral pleural effusions. And her peripheral smear showed dimorphic anemia, neutrophilic leukocytosis, and thrombocytopenia. Next slide, sir. There she was diagnosed with right lower limb cellulitis, acute kidney injury, thrombocytopenia, anemia, unconjugated hyperbilirubinemia, secondary to snake bite. And there she had received injection cefoperazone sulbactam, injection clindamycin, injection pantoprazole, paracetamol, and chimeral 4 tablet. And they had also done magnesium sulfate and glycerine dressing to the right lower limb, to the right leg. And she underwent 4 sessions of hemodialysis as the patient was anuric and elevated urea and creatinine. And she had also received 1 unit of SDP transfusion and 2 units of PRBC transfusions during her hospital stay. Next slide, sir. So during her hospital stay, she had persistent drop in hemoglobin, and in view of worsening condition, that is persistent nausea, vomiting, and shortness of breath, she was referred to a higher center for further management. And she presented to our hospital on the 24th of November, sir. Next slide.
Anything to ask, sir? Narendra, sir?
No, what was the urea at that time? You mentioned creatinine. What was urea?
Yes, sir. So urea was around 150, sir, to start off with.
Potassium?
On the first. Potassium was around 4.5, sir.
ABG? Bicarbs?
We don't have a record of the ABG in the previous hospital, sir.
Okay, what do you think the patient probably had? What is that until this time? What do you think?
Yes.
What is happening? Now you know that it was a snake bite.
Snake bite.
What do you think? What was the snake and what was going on?
So, so this was a snake bite, sir. So probably a hemotoxic snake bite with local envenomation in the form of cellulitis of the right lower limb. And she also had systemic features like drop in hemoglobin and thrombocytopenia and acute kidney injury. So
cause of thrombocytopenia?
So probably the venom-induced consumption coagulopathy could be kept in mind at this point, sir.
Right. Okay. Yes.
Yes. Next slide, sir. So on arrival in ER, sir, her airway was patent. Breathing, her respiratory rate was around 20 per minute. BP was 140 by 100. She was conscious, oriented to time, place, and person, sir. And we had exposed and examined for other injuries. And she was pale, icteric. She was afebrile. Her pulse rate was around 92 per minute. Saturation was 99% on 4 liters of oxygen. And on auscultation, there was bilateral decreased basal air entry, sir, and bilateral basal creps. CVS, S1 and S2 were heard. And per abdominal examination, it was soft, but she had tenderness in the right hypochondrium. And there was bilateral pitting pedal edema, sir, up to the knee, right more than the left side. And the right leg was warm to touch. So on presentation in ER, sir, this was the ABG, which showed metabolic alkalosis, sir. Her pH was 7.42, PCO2 of 39, PO2s of 95 on 4 liters of oxygen, and her bicarbs were 25.2, sir, and lactate was 0.9. And her chest X-ray showed bilateral blunting of the angles, sir, CP angles, costophrenic angles. Next slide, sir.
No, stay back.
Okay.
How do you explain this pH in a anuric patient?
Sir, anuric, but she had already undergone 4 sessions of hemodialysis outside, sir. So probably contraction, and she had received Lasix also. So probably contraction alkalosis.
Contraction alkalosis. And what was the urine output at the time when she
was
presented?
anuric, sir. When she came to us also, she was anuric, sir.
Do you think this is compatible? Anuria and alkalosis with respiratory rate of 20 only, not 22.
20. Yes, sir.
Do you think it is compatible? Did you try to recheck the ABG?
Yes, sir. She never had metabolic acidosis, sir.
Do you think a case of anuria would never have acidosis? What were the indications for dialysis?
In her condition, she was anuric, sir, and her creatinine was more than 4, sir, to start off with.
Is creatinine of more than 10 an indication for dialysis? I've gone 2.5 times so far.
Sir, actually, the indications are signs of uremia, sir, like uremic encephalopathy, uremic pericarditis.
Did she have any one of them?
No, sir. She had mainly fluid overload, anuric, and creatinine was elevated.
What was the sign of fluid overload?
She had respiratory distress, sir.
Do you think so? What was her SpO2 without oxygen?
Around 86 to 88, sir.
88.
Yes, sir.
And with 4 liters, it was 99.
Yes, sir.
Okay. Proceed.
So next slide, sir.
Yeah.
So in ER, she had received injection cefiperazone sulbactam 1.5 gram IV stat, sir. Injection clindamycin 900 milligrams IV stat. Injection pantoprazole 40 milligrams IV stat. Injection ondansetron 8 milligrams. And injection paracetamol 1 gram IV, sir.
Do you think it is a good prescription? Good antibiotic. What was the initial thought process? What actually she is suffering from?
She's suffering from cellulitis, sir.
And
Acute kidney injuries, sir.
so what for cephalosporin?
Sir, to mainly cover gram-positive and gram-negative organisms post snake bite.
Do you think
can cause-
she has any evidence?
Want to touch?
No, as a prophylactic.
What is
she
the-
had signs of
What is
cellulitis,
the most important side effect of cephalosporin? One of the most important side effects of cephalosporin. Have you observed ever cephalosporin has to be stopped in a patient in ICU for some reasons? This per se may induce bleeding diathesis. Cephalosporin.
Okay, sir.
This is anti-vitamin K.
Okay, sir.
Anyway, why was paracetamol 1 gram IV straight given?
She had pain abdomen, sir.
Okay.
Yes, sir.
Pain abdomen. Or
Yes,
pain,
sir.
pain,
And
pain,
pain in her right lower limb and pain abdomen, sir.
With pain abdomen respond to injection paracetamol? Was it a colicky pain or a non-colicky pain or a visceral pain?
It was like a dull aching pain, sir. Right hypochondriac pain. Mainly tenderness she had and pain, sir.
So it was a liver pain, pain induced at liver level, hepatic
Yes.
pain. Okay.
Yes.
And clindamycin 900 milligram. Okay. Why it is 900 milligram?
For a gram-positive cover and...
Is it for gram
an
positive?
anaerobic cover.
Yeah,
Anaerobic, sir.
Anaerobic.
Anaerobic. Yes, sir.
Did you do Procal?
So Procal was initially in the outside hospital around 5, sir.
And in your hospital?
We have done CRP, sir, in our hospital.
CRP would be high in any case.
Yes, sir.
CRP is not evidence of infection, it is evidence of some inflammation. Right. Okay, let's go ahead.
So these were the initial labs, sir, in our hospital. Her hemoglobin was 6.1. Her platelets were 49,000, sir. Her urea was 98 and creatinine was 4.2, sir. Potassium was on lower side, sir, 2.4. Her bilirubin was 4.1. SGOT 238. And PT, INR and APTT were normal, sir. Her bleeding and clotting time were also normal, sir. And her peripheral smears showed normocytic normochromic anemia, microspherocytes, polychromasia, leukocytosis, thrombocytopenia, and schistocytes of 8 to 10%, sir. And direct and indirect Coombs test was negative, sir. Her CUE showed protein 3+, blood 2+, and pus cells 10 to 15. And we sent blood and urine cultures, sir.
What? Urine examination?
Yes, sir.
But
actually, she had produced around like 30 ml of urine, sir. So through that we have sent, sir.
Okay.
A complete urine examination.
Now, can we stop here?
Yes, sir.
What was the cause of anemia?
So probably hemolysis, sir.
Hemolysis.
Yes.
And what was the cause of platelets reducing?
Probably consumption coagulopathy. Consumption. sir.
And what is the evidence of consumption coagulopathy?
Actually, PTINR were normal, sir.
No, I'm not talking about PTINR. What is the evidence of consumption coagulopathy? Any clinical evidence of consumption coagulopathy on examination?
AKI. No, sir, there were no rashes like peticulae or.
Then how do you say it was consumption coagulopathy?
Probably like venom induced hemolysis and
Does venom cause that kind of rapid hemolysis? Was
it
there
can cause
evidence of rhabdomyolysis?
sir, elevated creatinine phosphokinase, sir, LDH, elevated LDH.
Did you
and,
look for that?
Yes, sir, we have done it, sir. It's coming in the next slide. I
Okay,
put it up
let's
in the next
see,
slide.
let's see.
So next slide, sir.
Yeah, I want to see that.
So one slide previous, yeah, this slide.
Hmm.
So one previous slide, sir.
Previous.
One more, sir. Yes. Sir. So her CPK was around 888, sir, and LDH was 3011.
So do you think she probably had rhabdomyolysis?
It could be, sir, with AKI and
No. AKI was probably because of rhabdomyolysis.
Yes.
Not it is
Yes,
because rhabdomyolysis because of AKI. Huh? But I do not understand bicarbonate 29 without having given any bicarbonates with okay.
Hypokalemia and bicarbonate on the higher side. What might be the any other reason specifically outside she might have received some?
Sir, a lot of diuretics she could have received, sir.
But there was no urine formation.
Passage, yeah.
No.
It was waste if at all she has received. Her bleeding time remains normal, clotting time remains normal, APTT remains normal, INR is okay. How do we call it consumption coagulopathy?
In Oxford Hospital, I think she had disease.
No, minors were normal.
Every time.
There was no evidence of bleeding anywhere in the body?
No, sir.
And why were the liver functions deranged?
So probably the hemolysis, sir, unconjugated hyperbilirubinemia.
OTPT, SGOT is also raised.
Yes.
And what is the fractional bilirubin testing result? Bilirubin 4.1. How much indirect?
The indirect bilirubin was on the higher side, sir. Indirect bilirubin was high, sir.
Potassium only 2.4 with this kind of hemolysis. Even then, a lot of potassium is released by hemolysis also, in rhabdomyolysis also, in AKI also. How do you explain all this? Very strange reports. And we are trying to fit it into a consumption coagulopathy with no evidence of, derangement of clotting or bleeding, parameters. Okay, let's proceed.
Next slide. So provisionally, we were thinking that it's a hemotoxic snake bite, sir, a viper bite with thrombotic microangiopathy with acute kidney injury and right lower limb cellulitis. Because our peripheral smear revealed a schistocyte count of 8 to 10%, sir. So we considered this diagnosis. Sir.
And that's okay. There has been some hemolysis.
Yes, sir.
There is no,
So in day one,
there's
yes,
no
sir.
problem about that.
So in day one in ICU, her vitals were stable, so she was on 2 liters of oxygen. And post this report, we did one session of plasmapheresis, sir, and 1 unit of PRBC transfusion was done. And
Plasmapheresis
for the thrombotic microangiopathy, sir. The high schistocytes. So we initiated on the first cycle of plasmapheresis in ICU.
Targeting what?
Like removal of the antibiotics, antibodies towards.
All right.
And so next we also corrected the dyselectrolytemia, sir. And we continued the antibiotics, limb elevation, analgesics, and other supportive
What
care.
did you do? What did you do to correct this electrolytemia?
So we corrected with potassium chloride, sir.
Would you give potassium to a patient with AKI, or you will just wait?
But the potassium was 2.4, sir.
What
So we have corrected it.
What was it causing in terms of clinical? You say ECG was normal?
No, there was no ECG changes, sir.
So, was it a dependable report?
Yes, sir.
Would you wait for another report? Or straight away we would jump to correction of hypokalemia, suspected hypokalemia. In a case where I would strongly expect high potassium. Okay, move.
And her lung ultrasound, sir, showed bilateral pleural effusion right more than the left side. And USG abdomen showed hepatomegaly and gallbladder wall edema. And her 2D echo screening was normal, sir.
What was the cause of gallbladder edema?
Sir, usually in hemotoxic snake bites with systemic envenomation, they can have these features, sir, like of polyserositis, like pleural effusions with
polyserositis. I can expect. I'm talking about gallbladder edema.
Gallbladder wall edema. Yes, sir. This is quite unusual, sir, but it was present.
Okay.
Next slide, sir.
What was the now you say respiratory rate was 27, and you gave
yes, sir.
4 units of blood.
Sir, we also dialyzed her, sir, on that day, on the first day.
No, that's okay. You did 4 sessions of plasmapheresis, 3 sessions of hemodialysis, 4
yes,
units. Sir. What was your target hemoglobin?
7, sir.
And what was the hemoglobin at arrival?
6.1, sir.
So how much 1 unit is expected to raise hemoglobin?
1 gram, sir. 1 gram, sir.
1 gram. Okay.
Yes, sir. So from day 2 to day 5 in ICU, sir.
So actually from 6 it will become 10.
So, but this was over a period of 5.
No.
Day 2 to day 5. Hello, Keerthana. There is some connection issue, sir.
Yeah, they are muted or they are disconnected.
Yes.
Yes, sir. Yes.
Now, would you tell me what were the indications for hemodialysis at this stage when potassium was 2.5? Patient was almost asymptomatic, and day 5 urine output has improved.
No, on admission, sir, urea
No.
creatinine were high and
Our
she was
urea
anuric.
No, that's okay. But what anuria was doing, what harm anuria was doing to her? Yeah, potassium was 2.5, pH was alkalotic. No acidosis, no hyperkalemia, no fluid retention, LV okay, blood pressure okay.
She had like bilateral pleural effusion, sir, and but otherwise,
all cases of dengue, you must be observing a lot of dengue these days.
yes, sir.
All cases of dengue fever admitted in hospitals have polyserositis.
Yes, sir.
Do you dialyze them?
No, sir.
All right, let's move.
Next slide, sir.
Why did you keep oxygen on in ward? What was the indication for moving her on 2 liters oxygen in the ward?
Sir, she still required oxygen because of the effusions. She was desaturating, sir, up to around 90%. So we shifted her with 2 liters of oxygen, sir.
Okay.
So these were the trend of the reports from in the first 5 days, sir. Her hemoglobin improved, sir, up to 7.9, and platelets also improved post plasma pheresis, sir, from 42,000 to 1.68 lakh. And her urea creatinine also were in the decreasing trend, sir. And LDH also was on the decreasing trend, sir. But and her urine protein creatinine ratio was 14.6, sir. And we also did an NT-proBNP at this time. It was around 12,700, sir. So next slide, sir. So on day 7, sir, she was shifted back to ICU in view of palpitations, respiratory depression, distress, and hypertension. So on examination, she was tachypnic, sir, with a respiratory rate of 35, tachycardic with a heart rate of 142. Her blood pressure was 180 by 110, and saturation was 99% on 4 liters of oxygen. On auscultation, bilateral creps were present, sir. So lung ultrasound was bilateral B profile. ECG showed sinus tachycardia, sir, and her ABG at this time showed metabolic respiratory alkalosis, sir, with a pH of 7.4, PCO2 of 28, and bicarb of 22. Her lactate was 0.9. The next slide. Next slide, sir. So her ECG showed sinus tachycardia, sir. And the next slide, sir. So initially we managed her. We put her on NIV support, sir. Put her on pressure support mode with 40% of FiO2 and 12 pressure support and 6 of PEEP. And we started her on NTG infusion at 5 microgram per minute, sir. And started her on diuretics, stat, and infusion. Her 2D echo screening at bedside showed moderate LV dysfunction, sir. And her X-ray showed bilateral pleural effusion, so bilateral blunting of the CP angles. We also got a HS tropi and NT-proBNP, sir. Her HS tropi was elevated and NT-proBNP was around 35,000. So at this point, we thought that she was in heart failure, so with fluid overload. So probably cardiac related. It was a LV dysfunction, so possibly myocarditis is what we thought. And
What was
next,
the ejection fraction? What was the
around
ejection?
40%, sir. Around 40%, sir.
Okay.
And one session of hemodialysis was also done, sir. Over the next 2 days, sir, she required intermittent NIV support. And on day 9, in view of worsening respiratory distress and desaturation, we intubated her, sir. Her initial ventilatory settings were a volume control with FiO2 of 40, respiratory rate of 22, tidal volume of 406 PEEP, sir. This was her ABG, sir. Metabolic acidosis with respiratory acidosis, sir. pH of 7.25, PCO2 of 50, bicarb of 18. Then for the heart failure, sir, we started her off on dobutamine infusion and also Lasix infusion, sir. And we managed her with fluid restriction of around 1 to 1.5 liter per day. So slowly and because of persistent respiratory distress, sir, we got a CT chest done which showed bilateral moderate pleural effusion with underlying collapse consolidation. Next slide, sir. So then we gave her spontaneous breathing trials, sir, and we extubated her on day 11. Even post extubation, she required intermittent NIV support, sir. So we did a repeat USG chest, which also suggested the same thing: pleural effusion, right more than the left. So we did a pleural tapping on the right side, sir. Around 800 to 900 ml was tapped. After this, the patient was symptomatically better, sir. The Lasix infusion and dobutamine infusion was tapered and stopped, and her LV function improved, sir. Her ejection fraction improved to around 50%. And on day 15, we shifted her out, sir.
What was
And
the character of pleural fluid?
It was a transudate, sir.
Okay.
Yes, sir. And later on, we discharged her from the wards.
So, can you, Chandana, can you sum up?
Sir, actually, 36-year-old female came presented with a snake bite. So, in outside hospital, she received 15 vials of ASV. In outside hospital, she had a progressive drop of hemoglobin and platelets and gradually increasing creatinine. And there is a decreased urine output. From there, she came here. So, in our hospital, she is having right lower limb tenderness, swelling, and warm to touch, looks like cellulitis. So we, after coming here, we continued the antibiotics, and we have given her plasmapheresis and dialysis. Progressively, she improved and shifted to ward. After that, she had breathing difficulty and desaturation, came to ICU. So there we evaluated and found her patient heart failure with reduced ejection fraction and probably secondary to myocarditis. So she was intubated, and later she symptomatically became better, extubated on day 11, and progressively she improved and got discharged.
What was the cause of myocarditis, you think?
So probably venom-induced
Yeah.
myocarditis, sir. Myocardial injury.
You have seen that before also? Myocarditis because of snake bite.
But in the guidelines, they have mentioned that it can
It can be,
happen,
yeah.
sir. Like myotoxicity.
No, my question was direct one.
No, sir, we didn't see.
Of
No,
course, it can occur. It has been reported though, but have you
Yeah.
seen?
No,
we
sir, we have not seen.
What is the commonest snake you see in Hyderabad area?
Viper, sir. Russell's
Viper.
viper.
Russell's viper. It did not cause any neurological injury.
No, sir.
No, sir.
No,
If it would to cause any neurological injury, what type of injury it would be?
A neurotoxic injury, sir. Probably
At what level?
neuromuscular junction, sir.
Neuromuscular junction.
Yes, sir.
It has several parts.
Post-synaptic is
Post-synaptic.
cobra bite, sir, and presynaptic is crate.
Good. Presynaptic. Right. So, you know about neostigmine test?
Yes, sir.
What is that?
Sir, in post administration of ASV, if the patient does not improve after the second dose of ASV, we give a trial of atropine and neostigmine, sir. That is 0.6 milligrams of atropine and 1.5 milligrams of neostigmine. So if there's a recovery in the doses after this, it means that there is a response to this, and this can be repeated up to 5 doses, sir. So if it doesn't respond beyond the third dose, it probably could be a neurotoxic injury secondary to the crate bite. And in those cases, we'll have to administer calcium gluconate, sir, because it's a presynaptic neurotoxin, and calcium would help in improving.
Now tell me. So the diagnosis here, you still think what was the cause of AKI? Microangiopathic hemolytic anemia appears to be a reasonable diagnosis.
Yes, sir. Microangiopathic
Now,
hemolytic anemia.
I want to understand from you, did you really rule out any infection? You have never talked of culture reports.
So culture reports were negative, sir.
So, did you stop cefoperazone?
No, sir.
Why did you continue with cefoperazone?
Because outside, she had already had hospital day of 5 days, and her procal was elevated. So
Elevated? Only you
it
say it was 5.
It was 5, sir.
And you did not repeat it?
We did not repeat it, sir.
And you know the worst side effect of all these cefoperazone, sulbactam, even ceftriaxone. Ceftriaxone in particular is very notorious to cause bleeding. It's just contraindicated in any bleeding disorder.
Okay.
Right. So, and clindamycin dosing does not have to be, recalculated because of renal problems for at least first 48 hours. You can give full doses of clindamycin. Number 2, SDP, you gave SDP also in your hospital?
No, sir.
No, it was given outside.
Outside hospital, sir.
Right. How do you explain, again, I'm coming back to, are you convinced about the ABC reports, alkalosis, hypokalemia in a case of rhabdomyolysis, microangiopathic anemia, so much of hemolysis. Hemolysis itself would produce a lot of hyperkalemia.
Hyperkalemia.
Rhabdomyolysis, if at all it is there, it will also produce a lot of hyperkalemia.
Yes, sir.
What was the BP when you started dobutamine infusion?
We started it after controlling the BP, sir, around 110 to 120, sir.
120. And why is using NTG is your routine practice in your hospital for hypertension?
Yes, sir. Probably she also had tachycardia, so probably labetalol could also have been used, sir. Tachycardia and hypertension.
So you have said you have used NTG.
Yes, sir.
So I would recommend labetalol.
Labetalol.
So what prevented you from using labetalol? Why did you not repeat procalcitonin? Or did you ever think about, weaning off the antibiotics?
Yes, sir. Towards the end, we did, sir. We didn't repeat because she didn't have fever. No,
Towards
she
the
didn't.
end?
No, sir. Like,
Antibiotic is antipyretic or
no, sir.
anti-infective? So you
No,
said
we didn't repeat Procal because she didn't have any fever spikes or any signs of infection or sepsis, sir.
so. You are
TLC.
contradicting. So cephalosporin was continued. Still cephalosporin, when you yourself are not convinced that there was any infection, what was the good reason to continue with cephalosporin? That's exactly what I, emphasize time and again. Our over dependence on antibiotics. They do not deliver. They induce a lot of problems. And thankfully, the patient did not deteriorate. The bleeding did not recur. Anyway, so, but you have presented it very well, very confidently.
Thank you, sir.
But there are lots of knots to be resolved in this case. I have not understood the alkalosis. Second time, when you are saying with 7.45 pH, you don't have to call it alkalosis. 7.45 is the upper range of normal pH. Bicarbonates were just 22 or 24.
Yes, sir.
CO2 was also 28 only. So it could not have been alkalosis. And
Was there any gastrointestinal losses, something like that? Because potassium is on the lesser side, metabolic alkalosis, both going hand in hand.
Sir, actually, initially she had vomiting, sir. She presented with recurrent episodes of vomiting, but no episodes of loose stools, sir.
now, Keerthana, can you tell me, there is a plain and simple case of gastroenteritis, profuse vomiting and diarrhea, coming to you with hypovolemic shock, ultimately into AKI. What do you expect in this patient? Do you expect hypokalemia, alkalosis, or acidosis with hyperkalemia if this patient has AKI? The only problem with this patient had been simple vomiting and diarrhea. Hypothetical case.
Yes, sir.
Hypovolemic shock with AKI.
So the severe vomiting will cause a metabolic alkalosis picture.
No,
But
no, no.
like-
I'm not going into details. A patient has landed in your ER or ICU, a 40 years old lady, healthy lady otherwise. She had been touring and eating outside, develops profuse vomiting and diarrhea for unrelenting for almost 48 hours, goes into hypovolemic shock, lands into AKI. What is the most probable ABG?
Metabolic acidosis, sir.
Metabolic acidosis. Any amount of vomiting and diarrhea leading to AKI will induce metabolic acidosis. Seldom produce alkalosis, seldom produce hypokalemia. So this is a difficult proposition. So there was a need to repeat ABG. There was a need to repeat procalcitonin, review antibiotic. Antibiotic should be reviewed every second, third day. Should we continue with the antibiotic, or we can really do away with antibiotic? And we would have continued with clindamycin, of course, because you had limb necrosis or inflammation. So, and cephalosporin was not helping there at all.
So in your case, I think the snake was not identified. Na?
Not
Suppose
identified.
if there is a unknown snake bite, how do you approach syndromic approach?
So first, when the patient is presented, first we'll ask the signs and symptoms, how they presented. We'll check the lower limb, any signs of local swelling and pain, anything, and we'll ask any bleeding manifestations are there, and we'll check any neurotoxic, any symptoms of the ptosis, and dysphagia, dysarthria. Depending upon that, there is a syndromic approach so that we can come to a diagnosis of what kind of
What type of?
snake. So
5 times.
there are 5 types of syndromic approaches. So if there is a local envenomation with bleeding, it could be viper. And along with that, if there is any like it danger, it could be Russell's viper. So only neurotoxic with the presentation of neurological symptoms like dysphagia, it could be a crate, and local symptoms with paralysis, neurological symptom, it could be cobra. And paralysis with bleeding manifestations, it also could be a viper.
So
So
how do you
depending on the onset of
A patient after snake bite is brought to you, and referred from another hospital with apparent brain death presentation. What would you do? Some
no,
hospital
sir,
has
the
some hospital has told the patient looks brain dead, and they start talking about organ transplant. The patient is not convinced, so they remove the hospital from patient from that hospital and brings the patient to you. The patient has dilated fixed pupil, not responding at all. There is a absolute complete respiratory paralysis. You intubate the patient in hurry, and now you have a patient who's totally limp, not responding, dilated fixed pupil.
So we cannot declare this patient brain dead at this point of time, sir, because these patients can present in this state or even in a locked-in state, like a locked-in syndrome. So first treat the patient with ASV and atropine, and then go ahead, sir. But at this point of time, we cannot
Neostigmine for brain dead patient?
no.
No.
But
Tell me one single treatment modality for these patients.
yes.
Huh? No,
Yes.
nothing. No. Ventilate these patients very patiently.
Yes, sir.
Very patiently. It may require a week, maybe require 2 weeks. Sometimes it may require 3 weeks. And recovery is absolutely rule.
yes, sir.
So never give up apparently for brain dead patient. At my age, I've seen at least more than 10 patients who have been either referred or they came on their own as brain dead patients. We have a lot of cobras in our area. So this happens with cobra bite.
Cobra.
Yes.
Yeah, and sometimes with crate bite. Seldom with viper. And
Right.
don't try neostigmine in these cases. You may land up into another problem, because if you forget to use atropine, you end up in a disaster. Actually, most of the places they said mix atropine with neostigmine. Actually, atropine should precede neostigmine. First give atropine, then give neostigmine. So there is a definite protocol about it. But never tell the patient that he is likely to recover. You never know whether, tell them that we will try, and miracles do happen, and we have lots of reports from all parts of the country where they have reported survival of such patients.
So, Chandana, what is the protocol for whole blood clotting time, as Sir was telling?
So this whole blood clotting time, we will see whether to diagnose what kind of a snake bite. Sir. So usually we'll take this 2 ml of blood into a plain glass tube. So, and we'll keep it stand for 20 minutes. And after 20 minutes, we'll just try to tilt the tube. If it is not clotting, then the snake, which is a chemotoxic snake. And
How do you do this 20 minutes clotting time? How do you perform it by the bedside?
We'll directly collect, sir, without without put in the syringe. We'll take this into the vial, sir, plain glass vial.
Right, plain glass slide
Plain-
or yeah,
And glass tube.
and
glass tubes.
right, and then what is the next step?
So
Keep it
we'll keep
undisturbed.
it stand still for 20 minutes, sir.
You
And-
wait, or do you do something in between?
We'll send all other.
No, sir. Leave it
We'll leave it
undisturbed for
undisturbed
20 minutes.
Don't
And after-
shake it. Don't shake
Don't
it
shake it,
anytime
yes.
during 20 minutes. Don't never shake it.
No,
That is very important. You will break the clot if it is, forming,
it is.
and you will have a, false picture.
Okay.
Now I'm giving you a hypothetical case. A 25-year-old young man with known snake bite, with bleeding diathesis, ARDS, abdomen full of blood, respiratory rate 60, saturation some 60, on a PEEP of 22. What would you do? I just want one single answer. What would be the therapeutic answer to this case? It is day 8. Abdomen has about 8 liters of blood.
Abdominal compartment syndrome.
It is there. Yes. So you are into the right direction.
Decompression,
Decompression.
sir. Or
Wow.
laparotomy.
Laparotomy is the answer.
Laparotomy.
But it will take very hard work on your part, pleading with the surgeon to perform a laparotomy, because he would most of the time say the patient would collapse on the table. It will be blood bath, since there is a bleeding diathesis, and there will be blood bath. I had to really hold the surgeon by his feet to make him operate, do a laparotomy. This patient particularly I am talking, he was kept on a PEEP of 45, respiratory rate of 80, 100% FiO2 for almost 2 hours, praying to God all the time, and as soon as clot was removed, 5 liters, he almost stood up on the OT, on the OT table itself. No, I'm saying more than, in a sort of indicative language. So the patient was discharged on day 5 after laparotomy. The recovery was so swift. He was almost the anesthetist inside. Probably he wanted to send the patient without a tube. So it was an apparent ARDS. Anyway,
Yes, sir.
you have faced questions, taken questions very sportingly, bravely, and we have not been very kind to you at all. So,
Sir,
so anything more? Thank
anything?
you.
Yeah, there are some questions, sir.
Yeah.
Take up. How much time we need to wait till we declare brain dead?
No, if we are convinced that it is cobra or snake bite, and cobra or snake bite induce apparent brain dead like situation, there is no time limit. It's an indefinite until you really think that it is really brain dead. You prove by all angles.
Regarding ASV protocol, what is the ASV protocol?
10 vials on
10
arrival,
And
and
you do 10 vials after
1 hour.
1 hour.
If there is no improvement in the
subsequent protocol is very open. But to my mind, you can go up to total 25 vials. More than 25 vials. I think more than 10 vials itself is probably of not much use.
Yeah.
But definitely more than 25 vials will be going overboard, because you have more chance of producing ASV-induced problems than venom-induced problems. Now, what do you do if you have ASV-induced shock
Anaphylaxis.
during delivery of the ASV? What do you do?
So initially stop the infusion, sir, for a while, and take care of the airway, breathing, circulation, and administration of adrenaline, sir. 1 milligram IV stat.
IV, yes.
Yes,
So if you
IV.
give it subcutaneous in a shock patient, it has no use.
They absorbed.
Do you
absorption
give
is
any?
erratic.
Do you give any adrenaline before initiating ASV?
Prophylaxis. Actually, there's no role in prophylactic dose of adrenaline, sir. But in
Hydrocortisone?
patients, hydrocortisone can be given, sir, stat dose, and
But
also
what does hydrocortisone do?
Anti-inflammatory, sir, to decrease.
No, it does not deliver anything, except that we feel that we have given hydrocortisone. Also, it does not help in any manner. Yes, chlorpheniramine maleate can be given.
Yes, sir.
So don't stop ASV. It
Yes,
should
sir.
go on.
After stabilization of vitals, he can
No. There is no point in stopping ASV.
Okay.
Because ASV is not going to kill. It never kills the patient. Seldom kills the patient. This shock in most all conditions would be reversible. It may take some time, but it is always reversible. Yeah. More
I think
questions?
across pregnancy and the children also the same dosage. So yeah, which has to be.
Yes. Treat a pregnant lady and the child with similar doses in a similar manner. There are no data regarding management of a pregnant woman differently or harms induced to pregnant woman. There is very little understanding about transfer of snake venom or ASV transplacentally. Very little is known about that. Why so that dose in child of 6 months also remains the same as in adult?
Because the venom injected is the same amount, sir.
Right.
Whether it's a child or an adult.
Snake doesn't know whether he's biting a infant or an adult.
Regarding ASV polyvalent versus monovalent, why India is not producing monovalent vaccine instead of polyvalent?
Because in India we have different snakes in different parts of our country, and most of the time we fail to know about a particular type of snake. So it is justified to have a polyvalent vaccine, but it also does not have any vaccine against any anti-venom against scorpion bites. So that's the problem. But that kind of anti-snake venom is available in countries like Far East, Vietnam, Laos, Cambodia, these countries, because the incidence of scorpio bite, sting injuries, and deaths are much more common in those areas. But we do have scorpion bite induced shocks, which does not respond to anything.
Yes.
Sometimes it does respond apparently to alpha blockers.
Alpha blockers.
Prazosin-like substances.
That is.
But one or two cases of scorpion sting induced shocks we have seen. I remember all those patients perished. We couldn't retrieve any.
Yes.
Yeah.
Severe myocarditis and most of the times die.
And never ever put a IV line in the limb which is involved.
Yes.
You know, this is a very important thing. The nurse in hurry would put a IV line, irrespective of the limb. Most of the time they are handling the involved limb, so most of the time you find there is an IV line in that particular limb only. Some of us have a feeling that let us put the line on the same side, so the drug distribution will be better on this side, which is seldom the case.
Yes, sir. So I think
What is your ideas about tourniquet?
Actually, we will not advise the tourniquet, sir.
Huh?
We have to immobilize the entire limb.
There is a snake bite in your neighborhood, and you are the first person. What first aid you will administer?
First, immobilization of the limbs to prevent, because the movement will increase the absorption of the toxin. So immobilization is the only thing we'll do, sir. Tourniquet is not advised.
Right, immobilization. And what is specific immobilization? You can probably talk.
Pressure immobilization.
Yeah, pressure induced immobilization.
Pressure induced immobilization.
Right. Where was this trial done? Pressure induced.
Sutherland method. Not sure.
Australia. So, any more questions, Dr. Kaladhar?
I think almost been answered, sir. One person is asking ASV dose protocol, but anyway, you answered it.
We have answered that.
Yes, sir. Yes, sir. Clindamycin, is it better than metronidazole for anaerobic coverage? One person is asking.
You know, antibiotics are glorified medical formulas. I feel we all have over-dependent on antibiotics for decades. Without knowing we know very little about antibiotics, and we use them the most. So most of the time I will give you flimsy answers, what I have read in books or journals, which have never stood the test of time, which does not resolve problems, which does not save patients. What saves patient is the actual specific management protocol that we apply, like ASV in snake bite, immobilization, ventilation, prevention of infection, head up. Antibiotics, to my mind, they come probably at the last.
Yes, sir.
And this is because, probably because I have little hair left on my scalp, or whatever is left are gray. So I can afford that. Probably you young guys probably would not adventure into that. But I'm fully convinced that we have been misled by the industry about application and use and usefulness of antibiotics.
You rightly said, sir. So one person is asking, like, can myocarditis still happen after ASV, after plasmapheresis, and after 10 days of snake bite? Is it a possibility?
Myocarditis?
Yes, sir.
Yeah, of course, yes.
Venom induced, it's a possibility.
Yeah, myocarditis can occur 2 weeks after. If a particular situation can induce myocarditis, it is a very, very slow process.
Yes, correct.
And we do not know whether in this case it was ASV or this snake venom.
Yes, sir.
One of the two. And if you go deep into the literature, one of the drugs that you probably might have used, that might have been responsible. You know, many times you will find that patients have been treating for lactic acidosis. You would say, oh, the blood sugar is 350, lactate is 15. There is severe metabolic acidosis. There is almost respiratory arrest-like situation, intubated, and the patient gets treated for, sepsis, septic shock. And in the evening, you find that the patient gets intubated, extubated. Blood sugar is 85 because you were giving insulin and lactate comes to 2, without realizing that you have been using something containing propyl glycol, solvent containing formulation. Particularly look for that if the patient is coming from OT. Look for if anything has gone into the intrathecal area, because you use a lot of these intrathecal drugs these days. So these are very notorious problems. Anyway, thank you, Dr. Kaladhar.
Thank you very much, sir, for sharing your clinical acumen and clinical experience. It was really, we are privileged to have you on our platform.
It was a pleasure coordinating and interacting with, indulging with young people.
Thank you, sir.
And I wish to congratulate these young girls.
Dr. Keerthana and Dr. Chandana, thank you.
Wonderful presentation and discussion.
Dr. Keerthana and Dr. Chandana, thank you for bringing out the case which had a...
Thank you. But I advise go and talk to your bosses about the absence of acidosis, alkalosis. Why was that? And also about cefoperazone, sulbactam. Go and read, review. Right.
Thank you, Yashoda Hospitals and digital team for providing the platform. Thank you, sir. Good night. Good night, everyone. Thank you.
Thank you.